Hello, welcome students to the chapter Concepts of Care for Patients with Diseases Related to the Central Nervous System. We're still reviewing the ones pertaining to the brain, and right now we are finishing this chapter with two important topics. One is seizures and epilepsy, and the other one is meningitis. As a reminder, please pay attention to the all good to know and the NCLEX alert, because in these videos what I'm trying to do is to give you hints not only for the current exam but also for the final. So if you watch the videos, you know what is going to come in the final. Also, you are going to have valuable information that probably you're going to see in your HESIS exams and the NCLEX. So we are basically killing several birds in one shot with these videos. You have reminders for the current exam, for the final, for your HESI, and especially your NCLEX alerts. Okay, so let's start. Okay, seizures and epilepsy. A seizure is an abnormal, sudden, excessive, uncontrolled electrical discharge of neurons within the brain that may result in a change in level of consciousness, motor or sensory ability, and on behavior. Some seizures are caused by a pathologic condition of the brain, such as tumor. So let's watch this video and we are going to understand better seizures and epilepsy. Okay.
Epilepsy is a group of neurological diseases characterized by recurrent seizures. Seizures happen as a result of a sudden surge in the brain's electrical activities. Depending on which part of the brain is affected, a seizure may manifest as loss of awareness, unusual behaviors or sensations, uncontrollable movements, or loss of consciousness. The brain is a complex network of billions of neurons. Neurons can be excitatory or inhibitory. Excitatory neurons stimulate others to fire action potentials and transmit electrical messages, while inhibitory neurons suppress this process, preventing excessive firing. A balance between excitation and inhibition is essential for normal brain functions. In epilepsy, there is an up-regulation of excitation and/or down-regulation of inhibition, causing lots of neurons to fire synchronously at the same time. If this abnormal electrical surge happens within a limited area of the brain, it causes partial or focal seizures. If the entire brain is involved, generalized seizures will result. Partial seizures subdivide further into simple, partial. Depending on the affected brain area, patients may have unusual feelings, strange sensations, or uncontrollable jerky movements, but remain conscious and aware of the surroundings. Complex partial seizure, on the other hand, involves a loss or change in consciousness, awareness, and responsiveness. Generalized seizures subdivide further into absence seizures. This type occurs most often in children and is characterized by a very brief loss of awareness, commonly manifested as a blank stare with or without subtle body movements, such as lip smacking or eye blinking. People with absence seizures may not be aware that something is wrong for years. Kids who start having absence seizures in early childhood stand a good chance to outgrow them without treatment. Tonic seizures are associated with stiffening of muscles or increased muscle tone and may cause the person to fall, often backwards. Atonic seizures, also known as drop attacks, on the other hand, are characterized by sudden loss of muscle tone, which may cause the person to collapse or drop down. Clonic seizures are associated with rhythmic jerking muscle movements. Most commonly affected are the muscles of the neck, face, arms, and legs. Myoclonic seizures are sudden brief jerks or twitches of muscles. Patients typically react as if hit by a jolt of electricity. The most dramatic are tonic-clonic seizures, also known as convulsive seizures. These are combinations of muscle stiffening and jerking. This type is what most people relate to when they think of a seizure. It also involves sudden loss of consciousness and sometimes loss of bladder control. A tonic-clonic seizure that lasts longer than 5 minutes requires immediate medical treatment. Epilepsy may develop as a result of a brain injury, tumor, stroke, previous infection, or birth defect. Generalized seizures that start in childhood are likely to involve genetic factors. Epilepsy due to a single gene mutation is rare. More often, an interaction of multiple genes and environmental factors is responsible. Hundreds of genes have been implicated. Examples include genes encoding for GABA receptors, major components of the inhibitory circuit, and ion channels. Many genetic disorders that cause brain abnormalities or metabolic conditions have epilepsy as a primary symptom. The cause of epilepsy is unknown in about half of cases. Diagnosis is based on observation of symptoms, medical history, and an electroencephalogram, or EEG, to look for abnormal brain waves. An EEG may also help in differentiating between partial and generalized seizures. Genetic testing may be helpful when genetic factors are suspected. There is no cure for epilepsy, but various treatments are available to control seizures. Medication successfully controls seizures for about 70% of cases. Many anti-epileptic drugs are available which target sodium channels, GABA receptors, and other components involved in neuronal transmission. Different medicines help with different types of seizures. Patients may need to try several drugs to find the most suitable. Dietary therapy. Ketogenic diet has been shown to reduce or prevent seizures in many children who do not respond to medication. Ketogenic diet is a special high-fat, low-carbohydrate diet that must be prescribed and followed strictly. With this diet, the body uses fat as the major source of energy instead of carbohydrates. The reason why this helps control epilepsy is unclear. Nerve stimulation therapy, such as vagus nerve stimulation, in which a device planted under the skin is programmed to stimulate the vagus nerve at a certain rate. The device acts as a pacemaker for the brain. The underlying mechanism is poorly understood, but it has been shown to reduce seizures significantly. Finally, a surgery may be performed to remove part of the brain that causes seizure. This is usually done when tests show that seizures are originated from a small area that does not have any vital function.
Thank you so much. What a great video. I think we don't need to review the chapter. This video did it all. But anyways, we're going to review whatever is coming in your PowerPoint. I always follow the structure of your PowerPoint and complement with the information that is not there. PowerPoints are very basic, only they are having headers, full of headers. So at the end, we need to review the chapter, right? Anyways. So we know that a seizure is an abnormal, sudden, excessive, uncontrolled electrical discharge of neurons within the brain that may result in a change of level of consciousness, and depends on the area, as we saw in the video. It can cause changes in motor or sensory ability and or behavior. Some seizures are caused by pathological conditions of the brain, such a tumor. Pathophysiology, we need to understand that epilepsy is the umbrella, and under that umbrella we have the several types of seizures, right? Epilepsy is defined by the National Institute of Neurological Disorder and Stroke as a chronic disorder in which repeated, unprovoked seizure activity occurs. It may be caused by an abnormality in electrical neuronal activity, an imbalance in neurotransmitters, especially gamma aminobutyric acid, or a combination of both. Let's remember something, okay? Our body is basically, some authors, they are telling us that our body is between 75 and 85% water. And most of the cells are having electrical activity. So right there, you can kind of understand part of the causes of the seizure. There is an imbalance between the electrical activity of the cells and probably the fluids that are surrounding our body, especially our brain. Our brain is resting in a nice quantity of water. So We are going to see the causes of the seizures. On top of that, we have to consider the genetic, we have to consider any trauma or tumor. But basically, epilepsy seizures are related to the electricity of the neurons, okay? Types of seizures. Generalized seizures, partial seizures, which are focal, combined generalized and partial seizures are the types. So we have 5 types of generalized seizures. Generalized are the ones that is covering a lot of most of the brain, right? As the video described. May occur in adults and involve both cerebral hemispheres, right and left hemisphere. The tonic-clonic seizure lasting 2 to 5 minutes begin with a tonic phase that causes stiffness or rigidity of the muscles, particularly of the arms and legs, and immediate loss of consciousness. Clonic or rhythmic jerking clonus of all extremities follows after that. That's the tonic clonic. So first you're going to have the rigidity, and then you're going to have this rhythmic movement. The patient may bite the tongue and become incontinent of urine or feces. Fatigue, acute confusion, and lethargy may last up to 1 hour after the seizure postictal state or after the seizure state. This is very sad. Have you ever seen a patient with seizure? I had a colleague in the hospital. She was taking care of, basically she was cleaning the rooms, during COVID, and suddenly she just fell on the floor and was having this tonic-clonic seizure. It was impressive. A tonic seizure is an abrupt increase in muscle tone, loss of consciousness, and autonomic changes lasting from 30 seconds to several minutes. The clonic seizure lasts several minutes and causes muscle contraction and relaxation. The myoclonic seizure causes a brief jerking or stiffness of the extremities that may occur singly or in groups, lasting just a few seconds. The contractions may be symmetric in both sides or asymmetric in one side. In an atonic akinetic seizure, the patient has a sudden loss of muscle tone lasting for seconds, followed by postictal confusion. In most cases, these seizures cause the patient to fall, which may result in injury. That's true. My coworker, she fell in the middle of the hallway. Partial seizures, also called focal or local seizures, begin in part of one cerebral hemisphere. They are further subdivided into 2 main classes: complex partial seizures and simple partial seizure. We are talking here about seizures that are related to a small area. It's different from generalized, okay? Partial seizures are most often seen in adults and generally are less responsive to medical treatment when compared with other types. Complex partial seizures may cause loss of consciousness, syncope, or blackout for 1 to 3 minutes. Also, it's very common to see amnesia, loss of memory, because the area of the brain most often involved in this type of epilepsy is the temporal lobe. Remember, full-time position. Nurses want the full-time positions. Is the frontal, the tempora, the parietal, and the occipital. So this is occurring in the area of the temporal lobe, which is the temporal is on the upper part of the ears bilaterally, right? Complex partial seizures are often called psychomotor seizures or temporal lobe seizures. Okay, so then we have patient-centered care, older adult health. Complex partial seizures are more common among older adults, similar to those of dementia, psychosis, or other neurobehavioral disorders. They can be confused with this, right? New onset seizures in older adults typically are associated with conditions such as hypertension, cardiac disease, diabetes mellitus, stroke, dementia, and recent brain injury. Okay, so then we have simple partial seizure, remain conscious throughout the episode, and this is the only type in which patient remain conscious, the simple partial seizure. Okay, now there is a déjà vu, already seen phenomenon, perception of an offensive smell or sudden onset of pain. During the seizure, the patient may have one-sided movement of an extremity, experience unusual sensations, or have autonomic symptoms. Those autonomic, we have to remember, are the ones that we cannot control, like blood pressure, heart rate, the bowel movements. And autonomic changes include a change in heart rate, as I was mentioning, skin flashing, and epigastric discomfort. Perfect. So the etiology and genetic: primary or idiopathic epilepsy, which is the umbrella of the seizures, right, is not associated with any identifiable brain lesion or other specific cause. However, genetic factors most likely play a role in its development. So primary is related to genetic factors, right? Secondary type of seizures result from an underlying brain lesion. I would say these are acquired, something happened, right? A lesion, most commonly a tumor or trauma. And also this may be caused by metabolic disorders like diabetes, for example. I'm going farther, probably endocrinologic disorder, something happened with the thyroid, right? Hormonal disorders, acute alcohol withdrawal, electrolyte disturbances, hyperkalemia, water intoxication, hypoglycemia. Those are changes in the fluids of our body, and again, they are affecting the electrical activity of the neuron. High fever, you see, the fever is going to cause dehydration, is going to cause evaporation of the fluids. That's why there are changes in the electrical exchange between electricity and water in the body. Stroke, head injury, substance abuse, again, fluids entering to our brain, and heart disease, right? So seizures resulting from these problems are not considered epilepsy. Various risk factors can trigger a seizure, such as increased physical activity, which is going to cause evaporation of fluids. Emotional stress is going to cause changes in the hormonal environment. Excessive fatigue, alcohol or caffeine consumption, or certain foods or chemicals. Now we are recognizing the cues by doing the proper assessment, and I don't even need to mention what we need to ask to the patient, as long as we know our all-cause mnemonic. Again, onset, location, duration, characteristics, alleviating or relieving factors, timing, and severity of the seizures, right? Also, we are going to ask about the presence of an aura, and this is very important, before seizure begin, which is called pre-ictal phase. Question whether the patient is taking any prescribed drugs or herbs, or has had head trauma or high fever. This is important. Assess an alcohol and any other illicit drug history. Ask about any other medical conditions, such as previous stroke or hypertension. So here are common examples of drugs. And this, basically, I was reading this table. This is NCLEX material mostly. Okay, I am not going to test you on this, but you should know this because it's coming in the NCLEX. Know your pharmacology, nurses, please. For example, phenytoin, fosphenytoin, these drugs are given for status epilepticus. Teach patient to expect side effects such as headache and drowsiness, especially when starting drug therapy. Frequent oral care and have regular dental exam if possible due to the development of gingival hyperplasia with phenytoin especially. Check if patients starting phenytoin are on warfarin. NCLEX, safety. You're going to come across many patients in the hospital that are taking anticoagulants. In the hospital, it's going to be heparin, not warfarin, right? But if they are at home, they are taking warfarin, and probably they are going to be prescribed phenytoin. So you need to know these side effects and considerations because it's part of nursing patient education. Patients should not be prescribed both drugs to prevent excessive bleeding and phenytoin toxicity. I came across a case like this when I used to work in home healthcare as a nurse. I was visiting patients and I was organizing their drugs, their pill dispenser, right, with the medications. And I found patient taking warfarin with a recent prescription of phenytoin. So if I didn't know, if I was not aware of the interaction, something could happen, right? It was under my license, so I was able to contact the doctor. Pharmacology is very important, nurses, please. Be aware that the desired therapeutic level of phenytoin is 10 to 20. Be aware that the desired therapeutic drug level for fosphenytoin is 1 to 2.5 mcg ml. So then you have your carbamazepine. This carbamazepine, this is very common in hospitals. So teach patient that drug may cause dizziness and drowsiness. You have to put all your fall precautions in place for this, okay? Monitor for a rash in patients starting carbamazepine. Be aware that this medication is also used for chronic neuropathic pain like gabapentin. Be careful, nurses. Be careful. You can have an accident in the hospital if you don't know your medications and the side effects. The benzodiazepines, you see the lorazepam, the clorazepate. These are medications that are going to be giving IV push in case of status epilepticus. Yeah, okay. So clorazepate is used to prevent patient seizures, monitor for multiple side effects, including hypotension and respiratory depression. This is big. Hypotension, a patient can fall, not because of drowsiness. This drug is because hypertension, okay? And it could be a respiratory depression, so you have to monitor. And when I was giving these medications, instead of checking vital signs every 4 hours, I was doing so like every 2, right? And I put my computer park in front of all the rooms of these special patients because you need to monitor what they are doing. You want to prevent falls and other problems. So gabapentin teach patients that any of these drugs can cause drowsiness and dizziness, especially when first starting. Then, as I was telling you, I want you to realize that okay, let me put this article here because I want to talk to you about this. You need to protect your license, nurses. I don't know if they taught you about this. The Center for Medicare and Medicaid Services, they have this hospital acquired condition reduction program and hospital acquired infection. I gave you this material because when you have a patient, for example, that acquire an infection of suddenly the patient got pressure ulcers in the hospital, or here you see in hospital fall with hip fracture rate. Can you imagine? You didn't monitor the patient, now the patient fall and there is a fracture. Hemorrhage, post-procedure, sepsis due to infection because they didn't clean the room, or you were not being precautious when you were inserting any IV or giving a medication. Who knows? Okay, maybe you have the infection due to proper IV insertion, or maybe the infection was caused by the urinary catheter. So, or maybe the patient was having the immune system low and you didn't monitor that. So when this happened, the government is not going to reimburse the hospital because these were caused at the hospital. These issues were caused at the is hospital-acquired conditions or hospital-acquired infections. So basically, it's a no-no. I know many nurses that the first time they had an issue with this due to fall or an infection, well, the manager was saying, okay, this is the first time, okay, we're gonna manage it. The second time, third time, that you're out of business. You're out of the hospital, and who knows what's gonna happen with your license. Be careful with that. Okay, know your pharmacology and know your procedures. That's why I don't think it's worth it to come to nursing school just to hear and to review PowerPoints. You need to go over your lectures. It's important. You have spent a lot of money in this program, so you have to be very thorough when you study. Okay? If the seizure is a new symptom, ask the patient or family if any loss of consciousness or brain injury has occurred. Often patients may have had a head or brain injury sufficient to cause a loss of consciousness, but may not, they don't remember at this time of the seizure, especially if it was during the childhood. And you know, all these videos and articles is in the supplemental material that I provided with every chapter. Okay, is there. You have them available. That's good to know. Seizure assessment must include childhood. Okay, so I am very happy. I recently was notified by YouTube that some people were subscribing to my channel, and they are from other schools. And I was very happy to know that they are appreciating that we have this review of the chapters, and this reviews includes videos. You don't have to look for anything else. It's already included in the review of the chapter. Okay, let's continue. Typical diagnostics tests include an electroencephalogram, CT scan, MRI, and a SPECT PET scan. Interventions: removing or treating the underlying condition or cause of the seizure, manages a secondary epilepsy and seizures that are not considered epileptic. In most cases, primary epilepsy is successfully managed through drug therapy. So basically, the non-surgical management, most seizures can be completely or almost completely controlled through the administration of anti-epileptic drugs, sometimes refers to anticonvulsants. Drug therapy: the primary healthcare provider introduces one epileptic drug at a time. And then after that, at times, seizure control is achieved only through a combination of drugs. So either if it's not working, he's going to increase the drugs or the dosage. The dosage are adjusted to achieve therapeutic blood levels without causing major side effects. So my thought on this is, if it's a primary type of epilepsy, right, there could be genetic. Okay, you can control that with drugs, this and that. But if it is a secondary type of epilepsy that is acquired through metabolic disorders, through consumption of alcohol, smoking, stress, this and that, these are factors that could be easy preventable. Okay, so there is no reason why to put your body in risk if you have the proper nutrition, you have good stress management, intake of healthy fluids, etc. And you stay away from toxins, right? Drug therapy: the primary healthcare provider introduces one epileptic drug and is going to include two or maybe a combination of drugs if necessary. Follow up on laboratory test appointments to monitor the patient's complete blood count. This is important. And liver enzymes, and assess for therapeutic drugs level. This is NCLEX material with Anticonvulsant medications, you need to do your CBC often and liver enzymes checkup for therapeutic drug levels. Most anticonvulsants can cause leukopenia and liver dysfunction, and we know what leukopenia is, right? Some drugs, especially the hydantoins, can cause gingival hyperplasia. This is your phenytoin. Observe for and report beginning gingival changes and perform frequent oral care to prevent permanent damage. If possible, have regular dental checkups. If the patient is started on these medications at the hospital, it's your responsibility, nurses, to check and to assist the patient on dental care, okay, on cleaning, please, oral cleaning. Seizures in women, hormonal changes from menstrual cycling and the interaction of oral contraceptives with anti-epileptic drugs require the primary healthcare provider and patient to be aware of a variety of guidelines. As I was telling you, hormonal also can cause this type of changes. Anticonvulsants can also contribute to osteoporosis in menopausal women. There is a risk already for osteoporosis in menopausal women, but if we add the anticonvulsant, the risk is going to be higher. In some cases, the anti-seizure effects of drugs can decline and lead to an increase of seizures. This is important. Because of this potential for drug decline and sensitivity, patients need to keep their scheduled laboratory appointments to check serum drug levels. Okay, phenytoin should not be given with warfarin. We know that. Teach patients that some citrus fruits and other NCLEX material, grapefruit is everywhere in NCLEX. Teach patient, and it's affecting some medications but not others. So you're going to see the intake of grapefruit is not advisable for patients that are taking ABC selectol that apply. Okay, so you need to know that. Teach patients that some citrus fruits such as grapefruit juice can interfere with the metabolism of these drugs. The interference can raise the blood level of the drug and cause the patient to develop drug toxicity. Seizure precautions include ensuring that oxygen and suctioning equipment with an airway are readily available. If the patient does not have IV access, insert a saline lock, especially if the patient is at significant risk for generalized tonic-clonic seizure, and we don't want to get to that level, right? The saline lock provides ready access if IV drug therapy must be given to stop seizure activity. Padded side rails to maintain safety is debatable, is controversial. Padded side rails may embarrass the patient and the family. So based on the protocols of the hospital, and honestly, most of the hospital I work at, they don't have this protocol. They don't want you to put the rails, the padded side rails. Seizure management, it is not usual for the patient to become cyanotic during a generalized tonic-clonic seizure. It's not unusual. It's kind of common, right? Some primary healthcare providers prefer to give the high-risk patient, older adults, critical ill or debilitated patient, oxygen by nasal cannula or face mask during the postictal phase. Nothing per oral. The oxygen is by nasal cannula or face mask during the postictal phase, right? So during a tonic-clonic or complex partial seizure, do not force anything into the patient's mouth, as I was telling you. Turn the patient to the side to prevent aspiration and to keep the airway clear. It's all about having the airway clear. That's why the patient is placed on the side. Remove any objects that might injure the patient. Suction oral secretions if possible without force. okay, because the patient is going to be moving and having these jerky movements. So I highlighted the most important. Do not restrain or try to stop the patient movement, guide movements if necessary. Record the time the seizure began and ended, and this is part of your all cards mnemonic. At the completion of the seizure, take the patient vitals. This is common sense. Perform neurologic checks, check for pulse, strength. Keep the patient lying on the side. Allow the patient to rest. Document the seizure, observation during the seizure, change in pupil size and eye deviation, level of consciousness. Basically, the tongue or lip biting. This is important too. How long the seizure lasts. And, okay, I don't know what happened here. And when the seizure, the last seizure took place, because it's important to monitor the frequency, right? If the seizure was preceded by an aura, okay, all these factors are important. Okay, I am highlighting this. Emergency care, acute seizure and status epilepticus management. Treatment with lorazepam or diazepam may be given to stop the clusters to prevent the development of status epilepticus. IV phenytoin or phenytoin may be added. Status epilepticus is a medical emergency. That's good to know. NCLEX material, medical emergency. And it's a prolonged seizure lasting longer than 5 minutes. I can say 5 minutes very fast, but when you see somebody having this status epilepticus in real time, 5 minutes looks like the whole day. Or repeated seizures over the course of 30 minutes. So in 30 minutes you have one seizure, then it stops, and then you have another one, and then another one, and another one. It is a potential complication of all types of seizures. Any one seizure lasting longer than 10 minutes can cause death because it starts to compromise different areas of the brain that controls vital functions. That's why it's important to identify and to take notes of the minutes. How many minutes? What is the presentation? Your all cards mnemonic here works wonder. Common causes of status epilepticus include sudden withdrawal from anti-epileptic drugs, infection, acute alcohol or drug withdrawal, traumatic brain injury, cerebral edema, metabolic disturbances, and basically it's all related to the fluids, how the chemical with the fluids, the interrelation between the chemical component part of the body and the fluids. For example, if you leave your anti-epileptic drugs, the fluids around the brain are going to change, the electricity as well. And infection is going to cause inflammation in the fluids. Acute alcohol or drug withdrawal, again the same. Traumatic brain injury is going to cause edema, inflammation with these fluids, right? Cerebral edema, metabolic disturbances. It's basically, if it's primary or genetic, but if it's acquired, it's something that we can prevent. Critical rescue, convulsive status epilepticus may be treated promptly and aggressively. Establishing an airway is the priority for this patient care. Intubation by an anesthesia provider or respiratory therapist may be necessary. If not already in place, establish IV access with a large bore catheter and start your sodium chloride 0.9. The patient is usually placed in the ICU for continuous monitoring and management. Brain damage and death may occur in the patient with tonic-clonic status epilepticus. If untreated, this is very sad, if untreated, metabolic changes result leading to hypoxia, hypertension, hypoglycemia, cardiac dysrhythmias, or lactic metabolic acidosis. The drugs of choice for treating status epilepticus are IV push lorazepam or diazepam. all the nurses there that want to become ER nurses, ICU nurses, okay, or they want to work in the neurological unit. To prevent additional tonic-clonic seizure or cardiac arrest, a loading dose of IV phenytoin is given an oral doses are administered as a follow-up after the emergency is resolved. Teach the patient and family that serum drug levels are checked every 6 to 12 hours after the loading dose, and then 2 weeks after oral phenytoin has started. The desired serum therapeutic level is 10 to 20, and we know that NCLEX material. Surgical management. Patients who cannot be managed effectively with drug therapy may be candidates for surgery, including vagal nerve stimulation, as we saw in the video. Patients with generalized seizures are not candidates for surgery because, as we saw in the video, the surgery is gonna the procedure is gonna take a minimal area in the brain that does not have any relation with vital functions, and generalized is basically most of the brain. Patients with generalized seizures are not candidates for surgery because VNS may result in severe neurologic deficits. Yes. The stimulating device, much like a cardiac pacemaker, is surgically implanted on the left chest wall. An electrode lead is attached to the left vagus nerve, tunneled under the skin and connected to the generator. Observe 4 complications after the procedure, such as hoarseness, most common, cough, dyspnea, neck pain, or dysphagia, difficulty swallowing, and all this is related to the procedure that is tunneling this device, and these are the areas that could be touched or affected somehow. Teach the patient to avoid MRIs, microwave, shortwave radios, and ultrasound, diathermia, physical therapy, heat treatment. That's good to know. Care conditions and transition management. Discontinuing these drugs can lead to the recurrence of seizures or the life-threatening complication of status epilepticus. Yeah, some patients, they say, no, I feel much better, so they stop taking the drug, and that's a no-no. Refer limited income patients to the social services department for assistance because these drugs are expensive, right? Or to a case manager to locate other resources. And trust me, there are resources. There are resources. I used to work in a oncology clinic where patients came with no insurance, no resources for chemotherapy treatment, and there are resources. There are people that are doing donations, and most of the patients were able to get their treatments. There are resources. Patients and family education, health teaching for the patient with epilepsy. Understand the importance of having blood drawn for therapeutic or toxic levels as requested by the primary healthcare provider. Wear a medical alert bracelet or necklace, or carry an identification card indicating epilepsy. Balanced diet, proper rest, stress reduction techniques, which are going to help you with the fluids in your body and your brain and the electrical function of your neurons. Usually minimize the risk for breaking through seizures. Encourage the patient to keep a seizure diary to determine whether there are factors to tend to be associated with seizure activity. Last topic, meningitis. Woohoo! Okay, meningitis is an infection of the meninges of the brain and spinal cord, specifically the pia mater and arachnoid mater. Bacterial and viral organisms are most often responsible for meningitis, although fungal and protozoal meningitis also occur. Cancer and some drugs, notably NSAIDs, your ibuprofen, your naproxen, antibiotics, and IV immunoglobulins can also cause sterile meningitis. Regardless of the cause of meningitis, the symptoms are similar. So let's watch this video. We're almost done with this chapter, guys. Let's finish this chapter once and for all. A ver, let's see. Meningitis.
The brain, the command center to your entire nervous system. And yet the tiniest of germs can bring this complex organ to a halt. Meningitis is caused by germs that can do just that, an infection that attacks the lining around the brain and spinal cord. If not treated early, this culprit can be dangerous. Infectious meningitis can take many forms: viral, fungal, and bacterial, which can be the deadliest. But how does it make its attack on your brain? When bacteria gets near your face or in your mouth, they can break through the protective lining of your nose and throat. At this point, they can multiply at an alarming rate, infecting the bloodstream. The infection can spread to the meninges, a protective layer of tissue that pads your brain and spinal cord. This layer expands when fighting the infection. However, while it is protecting your brain, your body can suffer. The impact of the swelling will be seen in a number of ways. The inflammation produces a fever or headache. It can also interfere with memory and concentration. You may experience sensitivity to light. Muscles can ache, possibly a stiff neck. Bleeding under the skin can look like a rash. Things become most serious when the bacteria crosses the blood-brain barrier. This could mean more inflammation and swelling around the brain. The increased pressure can cause weakness of the muscles in the face. Blood clots can form, which can lead to stroke. Meningitis onset can be rapid, so being just as quick to understand your body's warning signs could prevent germs from doing long-term damage.
And that is why we are studying these nurses, future nurses. If we conduct a proper assessment and we are able to identify the hints, the cues of the disease, we can save many lives. Pathophysiology review, direct routes of entry occur as a result of penetrating trauma, surgical procedures on the brain or spine, or a ruptured brain axis, a basilar skull fracture, which we know already what is the basilar, right? We studied that in the previous videos. A skull fracture may lead to meningitis as a result of the direct communication of cerebrospinal fluid with the ear or nasal passages, manifesting with otorrhea, which is the ear discharge, or rhinorrhea, nasal discharge, or runny nose. So don't take it don't take it like, oh, I'm having a otorrhea or rhinorrhea and there is no problem. Just be cautious. And that is actually all areas related to your CSF. The infecting organism follow the track created by skull damage to enter the CNF and circulate in the CSF. CNF is your central nervous system and your CSF is your cerebrospinal fluid. Don't get confused. At this point, you should be mastering this. The patient with an infection in the head, ear, eye, nose, mouth, or neck, throat, has an increased risk for meningitis because of the proximity of anatomic structures. Exactly. Infections linked to meningitis include otitis media, as simple as that. A simple otitis media can cause meningitis. Acute or chronic sinusitis, okay? All of you that are suffering from sinusitis and you don't want to go to your ENT to double check on those sinuses, you must go. And tooth abscesses. Hello, dental care nurses. Twice a year, cleaning and regular checkup of your dentures. Here are also reports of rare cases from tongue piercing. Okay. The infecting organism may spread to both cranial and spinal nerves, causing irreversible neurologic damage. Is irreversible. That's why precaution is important. Increased intracranial pressure may occur as a result of blockage of the flow of the cerebrospinal fluid. change in cerebral blood flow, or thrombus, blood clots formation. Now, viral meningitis, we're talking about viral meningitis. The most common type is sometimes referred to as aseptic meningitis because no organism is typically isolated from culture of the CSF. Common viral organisms causing meningitis, pay attention nurses, are enterovirus, herpes, varicella zoster, also causes shingles, varicella, mumps virus, and human immunodeficiency virus. Okay? There is another organism called the Christococcus neoformans meningitis. Is the most common fungal infection that affects the CNS of patients with human immunodeficiency virus. We're going to talk about HIV in other lectures in this semester. The most frequently involved organism is responsible for bacterial meningococcal meningitis are Streptococcus pneumoniae, pneumococcal disease, and Neisseria meningitis, which is also known as meningococcal meningitis. Meningococcal meningitis is a medical emergency with a fairly high mortality rate, often within 24 hours. This is unbelievable. Unlike other types, this disorder is highly contagious. Outbreaks of meningococcal meningitis are most likely to occur in areas of high population density, such as college dormitories, military barracks, and crowded living areas. That's why they ask you for the vaccination before being accepted or entering these places. Action alert: people ages 16 to 21 have the highest rates of infection from life-threatening Neisseria meningitis, meningococcal infection. The Centers of Disease Control and Prevention recommends an initial meningococcal vaccine between ages 11 and 12 with a booster at 16 years. Adults are advised to get an initial or a booster vaccine if living in a shared resident college, college resident home, military barracks, group home. So recognizing the cues, perform a complete neurologic and neurovascular assessment, especially neurovascular assessment. Although the classic nuchal rigidity, stiff neck, and positive Kernig and Brudzinski signs have been traditional used to diagnose meningitis, these findings occur in only a small percentage of patients with a definitive diagnosis. So for those of you who wants to continue and get your master's degree, or you want to go for a nurse practitioner, it's all about the practice of different signs for you to diagnose diseases. Okay, I'm gonna show you the Kernig sign for you to know, even though it's not a definite diagnosis for meningitis, but this one is the Kernig.
The Kernig sign is designed to detect the presence of meningitis in patients who present with neck pain or headache. It's important to note that this test has been reported to be of low sensitivity. Therefore, a negative test does not exclude the presence of meningitis. With the patient in the supine position, flex the hip and knee on either side to 90 degrees and then gradually extend the knee. The test is considered positive if the patient reports that their neck pain or headache worsens with knee extension.
This is the Kernig sign, and the other one is called the Brudzinski sign. And then, even though the book says that these are not used anymore for diagnosis, I'm going to tell the story.
The Brudzinski sign is observed with some patients with meningitis. It's important to note that this test has been reported to be of low sensitivity. Therefore, a negative test does not exclude the presence of meningitis. With the patient in the supine position, flex the patient's neck. The test is considered positive if the patient reacts by flexing their hips and knees.
Okay, I know somebody who was having his hobby was to give food to the pigeons. So he was in the park and he was giving food to the pigeons, not 10 pigeons, but maybe 100 pigeons every day. Whatever I knew next, he was having meningitis. Okay, so it's very common if you are surrounded by such a quantity of pigeons, for example. It's well known that you can get meningitis. Okay, so be careful. I know they are beautiful, I love them, but be careful. Key features: meningitis, decreased level of consciousness, disorientation to person, place, and time, pupil reaction, and eye movement. Oh, I forgot to tell you the story. So, how he was diagnosed with meningitis when we went to visit him at the hospital. They didn't allow us to be there, so they did the Brusinski and they confirmed the diagnosis with the Brusinski sign. So, okay, key feature of meningitis: decreased level of consciousness, disorientation to person, place, and time, pupil reaction and eye movement, memory changes, and all these related to vital signs like fever and chills, tachycardia. Seizure activity may occur when meningeal inflammation and infection spreads to the cerebral cortex. Meningitis may be misdiagnosed as encephalitis, an infection usually viral of brain tissue and often the surrounding meninges. Diagnostic testing is needed to differentiate these two diseases. The most significant laboratory test used in the diagnosis of meningitis is the analysis of the cerebrospinal fluid. Patients older than 60 years, those who are immunocompromised, or those who have signs of increased intracranial pressure usually have a CT scan before the lumbar puncture. So, and we know already what is a lumbar puncture, right? A complete blood count is performed. The white blood cell count is usually elevated, well above the normal value. Serum electrolytes values are also checked to assess and maintain fluid and electrolyte balance. X-rays are done, air sinuses and mastoids are obtained to determine the presence of infection. A CT or MRI scan may be performed to identify increased intracranial pressure, hydrocephalus, or the presence of a brain abscess. Interventions: prevent meningitis by teaching people to obtain vaccination, all types of vaccination, mandatory vaccinations program for school enrollment and proof of vaccination. There are prerequisites for group home or dormitory experiences have significantly reduced the incidence of meningitis. I actually know a patient from the hospital who was having bacterial meningitis and he lost his vision. So be careful with this. For the patient with meningitis, assess the neurologic status and vital signs at least every 2 to 4 hours or more. As indicated, the priority of care is to monitor for early neurologic changes that may indicate increased intracranial pressure, such as decreased level of consciousness, and the patient is also at risk for seizure activity. And that's good to know. This is NCLEX material. So you have to check your neurological status, including a 6 cranial nerve defect, inability to move the eyes laterally. You see, the vision is involved. Sometimes they lose vision. And they start with this inability to move the eyes laterally, may indicate the development of hydrocephalus, excessive accumulation of CSF within the brain's ventricles. Other indicators of hydrocephalus include signs of increased intracranial pressure and urinary incontinence. Urinary incontinence can result from decreasing level of consciousness. Provider prescribe a broad spectrum antibiotic until the results of the culture and gram stain is available. Drugs may be used to treat increased intracranial pressure or seizures, and those are the most common is mannitol, and also anti-epileptic drugs. Safety. Place the patient with bacterial meningitis that is transmitted by droplets on droplet precautions, in addition to standard precautions. When possible, place the patient in a private room. That's exactly what happened to my friend. Stay at least 3 feet from the patient unless wearing a mask. Patients who are transported outside of the room should wear a mask. NCLEX alert. Perform a complete vascular assessment every 4 hours or more if indicated to detect early vascular compromise. And then you have the best practice for patient, society, safety, and quality care nursing care of the patient with meningitis. And you want to prioritize care to maintain airway, breathing, and circulation. Check your vital signs and perform neurologic checks every 2 to 4 hours. Your cranial nerve assessment, especially cranial nerve 3, 4, 6, 7, 8, among other important cares are positioned carefully to prevent pressure injuries. Also, you want to decrease environmental stimuli, and this is good to know. Provide a quiet environment. Maintain transmission-based precaution per hospital policy for bacterial meningitis. Monitor complications, increase intracranial pressure, vascular dysfunction, fluid and electrolyte imbalance, seizure shock. Wow. It looks easy, but it's not. Okay, we have completed this chapter and we have killed many birds in one shot. We are reviewing for this exam, Unit 1. We are reviewing for the final, and you are reviewing also for your HESI for next semester and your NCLEX. Okay, so if you take notes, you just need to go over your notes and that's it. I know it's a little bit extensive, the number of hours we are spending here, but once you have your notes, you just go over your notes and you will be ready for any test and you will remember Professor Matalana. Okay. Okay, guys, thank you for listening and thank you.